Good morning, everyone. You're welcome as you join us. We're just going to give it a couple of minutes to allow people to log in, and then we're going to get started. So again, I can still see some people logging in, and we'll just give another minute. Okay, so I can still see people are joining us, but this is being recorded, and in the interest of us starting and finishing on time, I am going to start the session today. My name's Sarah Benson. I'm the CEO with Women's Aid, and you are all extremely welcome to the Women's Aid webinar, which is a part of launching the Women's Aid Maternity Project. I'm really thrilled to welcome a number of leading experts today on the issue of domestic abuse and pregnancy. I'd also like to start by welcoming to this event our colleagues from the maternity and also the wider healthcare services, also colleagues from domestic violence services, policymakers, members of the media, survivors of domestic violence and abuse, and then families of women who have lost their lives due to domestic violence. You're all very welcome today. So just to remind that just because we are meeting virtually doesn't mean that we can't interact with each other. So we are encouraging all of our audience to submit their questions either via the Q&A box or through the comments on the Facebook live stream, which is also happening at the same time. And we would love if you would share the event online and share your thoughts and observations and use the hashtag of 16 days, because this is an event in the 16 days against violence against women, the international marking of advocacy to end all forms of violence against women and girls. Also to remind that there will be a recording available of the event afterwards, which we will circulate to all participants who have registered. So we are absolutely delighted today to have a host of speakers, including Dr. Lorna Jane O'Doherty, Dr. Siobán O Brien Green, Gillian Dennehy from Women's Aid, and we will also be joined for the question and answer sessions by Dr. Sally Pizarro after the presentations themselves. I want to also welcome Amanda and Tracy, who are signing for us today. And in order to make sure that the sign language is fully visible when any participants are presenting using a PowerPoint, we'll be turning off videos off just to ensure that we give a larger space on the screen for visibility of the ISL. I'd also, before I start, myself like to thank our colleagues in our strategic communications team and Tom also from Digital Revolutionaries for his technical wizardry, without which we would not be here today. So just for my colleagues on the panel, just a small bit of housekeeping, because I will also be in charge of our timekeeping. And so what I will do is only in the event of a slight overrun, if you run on by over a minute, I'll just turn on my video, which will be a gentle sign just to wrap up with your final points, so that we then will have plenty of time for the Q&A. And again, reminding to please share your questions through those two functions I mentioned earlier. So I'm going to be opening up just with a very brief overview of Women's Aid's new maternity project, just to set the scene and let you know about where the concept arose from and what we hope to achieve in partnership with our colleagues in 4 of the maternity hospitals in Ireland. So I will be sharing my screen now in a moment, and I'll be turning my video off. Okay. So I just think Tom's going to turn off my video. Very good, great, thank you. So effectively, Women's Aid, who have been a national domestic violence organisation established since 1974, have long been of the view that one organisation, one institution, one individual, one community cannot alone really effectively tackle what is the scourge of domestic violence in this country. 1 in 4 women suffer domestic violence over their life course. 1 in 5 by the age of 25, based on our own national research on prevalence. So these are shocking figures, and we have committed to work in collaboration and partnership with as many other really key stakeholders who also have a passion for combating and preventing domestic abuse. And one area we've long had interest in, but not the resources perhaps to actually do something really impactful, has been the area of maternity care. And going back now, probably 20 years, we have had really excellent collaborations with colleagues in hospitals like the Rotunda, around positive collaboration and mutual referral, examining the question of screening for domestic abuse. So this has long been an area of interest, and we know it's also long been an area of interest from those professionals at the front line in the maternity units. So in identifying the need, and I won't say too much about this because our esteemed panel will be speaking specifically to kind of making the case for this, we have been concerned that women's experiences of abuse are escalated at times of vulnerability, where you have where you have pregnancy, escalated and targeted forms of abuse, and in some cases where it's the first time somebody may be assaulted. And we know that frontline staff have appreciated having training, education, giving them the confidence and understanding so that they can relay their needs and concerns when they're right there at the coalface responding to disclosures. So we know that during pregnancy, you have also opportunities, and it can provide an opportune time for screening, for disclosure, and to, create enhanced supports at this very precarious time. So, as I say, we knew that there was, knowledge there, we knew there was experience there, we knew there was concern there, and from our side, we didn't have the resources to do what we would have wished to do, and indeed have been discussing with some colleagues in the maternity care setting. And so in 2019, we were absolutely delighted to, through fundraising and through grants, have secured income to do a pilot 3-year project. And the funding we've secured resources for the duration of this project, 2 full-time staff, 1 our project coordinator, Gillian Dennehy, who you're going to hear from shortly, who's the primary lead on the training and awareness and a policy component for Women's Aid, and a dedicated outreach worker, Kira, who is working already at these early stages of the project in conjunction with our colleagues in the Dublin maternity hospitals. And again, Gillian's going to speak a little bit about her work in her presentation. Also critically for a pilot, we have got the resources to secure an independent evaluation, which I'll say a little bit more about shortly. The awareness strand obviously requires design and printing and circulation, and so we secured a small budget for this. And we will also then do a public final event at the end of the project in conjunction with our partners, and secure the resources to do that, and hopefully have a really effective report to disseminate and make the case for the mainstreaming of this work, with the learning that we will gather as we go as well. I want to thank wholeheartedly the masters of the 4 hospitals that we are partnering with. We've the Coombe Women and Infants University Hospital, the Rotunda Hospital, the National Maternity Hospital in Holles Street, and the Ireland South Women and Infants Directorate, which is primarily our colleagues in Cork University Maternity Hospital. So from the outset, once we secured the funding, you know, we've been reaching out, having meetings. We want to really acknowledge that we're all working under pressure, and never more so than with the current and continuing global pandemic. So it is such a real testament to our partners that they have been so engaged as we start building our relationships, which are going to be, you know, the vital foundation for this project, exploring referral pathways, engaging on that work to develop pilot and evaluate training that will build on the expertise and experience that's already within these frontline multidisciplinary teams. Because we really believe that this can be one of those positive projects where some upfront investment of time, energy, and experience by us all will be an investment in greater connectivity and connections internally in hospitals and externally with specialist support agencies in service of women and children who are subjected to abuse at such a particularly vulnerable time in their lives. So the overall vision of the project is this: to enhance maternity hospitals and units' responses to victims and survivors of domestic violence and abuse through a jointly created, delivered and operated domestic violence and abuse training, awareness and referral program. So overall, this is the vision of the project, and I just have to emphasize again that this is very much a collaborative project, and we are working with the hospitals that we are, in recognition that much is already in place. We, you know, with expertise, knowledge, policy, and special social work teams in a number of cases as well. So this is firmly intended to be collaborative and developed with the relevant maternity hospital personnel, so that it is useful and adds value in responding to pregnant women and people who are being abused. Just in short, the project is a pilot, as I say, and therefore we have to be very careful to, you know, be very focused and precise in order that we can, through our independent evaluation, actually gather meaningful data. And then the objective then is that post-pilot we would have a model that we would be able to propose for a sustainable national you know, rollout of something that we will be you know, working on you know, since June, when Gillian has started with us and Ciara has started with us, but for the next 2.5 years as well. So the object then is to work on those 3 strands, primarily the training, internal training, and then the referral pathway to support that kind of wraparound continuation of support, both within and outside the hospital setting for the most vulnerable women. And then the awareness is just a really wonderful opportunity to collaborate, to do targeted, relevant to the maternity experience, you know, awareness raising tools and mechanisms to signpost both to supports within hospitals, to raising awareness of the national helpline, and the fact that, you know, we are all committed to supporting pregnant women who may be, you know, at risk and vulnerable to abuse. So the idea is that all staff, including our own, will benefit from these awareness and referral strands. And we also know that the 4 main hospitals, because they have told us, have identified the real need among some of the regional maternity units within the hospital groups who may have, you know, a lower level of resources. And so the training pilot, which will in each of the 4 hospitals involve a sample of midwifery, obstetric and social work staff, you know, which will be evaluated, but we will also do a sample with some of the regional units, which will be identified to us as by the main hospitals themselves as to whom we will engage in the pilot for this. So as I say, Gillian is going to speak a little bit more about the work that's been established to date, and I just flagged that the independent evaluation and the 3 strands that we're working on will also be underpinned by a current existing policy, research and also data collection. The structure of the project itself is currently that we have an internal advisory, our coordinator, Gillian, working with senior management within Women's Aid. There is an external advisory. We are absolutely blown away with the calibre of very high level expertise across both the health sector in terms of the HSE, TUSLA, the disciplines of social work, midwifery and obstetrics, patient representatives, and also colleagues from advocacy groups representing more minoritized and marginalized women, including traveller and migrant women. So we're just so delighted to have that expertise as an insight for advice as an external eye on the project. And then we have the operational side of things internally and externally, and we are currently reviewing tenders for the independent evaluation. So what we hope to achieve, and again, huge thanks to all our partners for coming on board to work on this important issue with us, is that what we are doing now is kind of laying the groundwork. Loads has been done, but we have another 2.5 years to actually start rolling this out, really learning, adapting as we go, and really making the case for fully resourcing a model of wraparound support that works across multidisciplinary teams in maternity settings and in partnership with specialist domestic abuse organisations. Ultimately, we hope all around the country with our colleagues in the other domestic violence services, all in service of women and children subjected to abuse. So I'm going to stop there. So I'll stop sharing my screen. So thank you again. And I am delighted now to welcome our next speaker, who is Dr. Lorna Jane O'Doherty. And Lorna is an Associate Professor of Abuse and Health Research at the Institute for Health and Wellbeing at Coventry and an Honorary Fellow of the University of Melbourne. She currently leads in a major study into mental and sexual health and service use experiences among survivors of sexual assault in England, which is funded by the National Institute for Health Research. She also was the principal investigator on the ESRC funded study about justice journeys in relation to sexual offences during the pandemic. And her other area of interest is practitioner responses to domestic abuse. And in this area, she's published a randomized control trial of general practice-based intervention for partner abuse in The Lancet, and has been instrumental in research evaluating the effectiveness of screening for partner abuse. This work is underpinning her presentation today, which is entitled Global Perspectives on Prevalence, Impacts and Intervention for Domestic Abuse During Pregnancy. You're very welcome, Lorna. Thanks for joining us today.
Thank you. Thank you very much, Sarah. Share my slides now, just a moment. Okay. So good morning, everyone. And thank you to Women's Aid for giving me this amazing opportunity to speak to you this morning as professionals engaging with women and birthing people at a critical point in their lives. And I say critical because pregnancy can be a turning point in the course of domestic abuse and an opportunity to break intergenerational transmission of trauma and abuse. I'll present a glimpse of our research in this area, along with global initiatives and resources for enhancing practitioner responses to intimate partner violence, especially in the context of pregnancy journeys. Now, I will interchangeably use terms like domestic abuse, domestic violence, and intimate partner violence, but of course I am referring to the same phenomenon. I'm firstly going to take a look at the hidden impacts of abuse. Indeed, many of the effects of intimate partner abuse are not so invisible once you know what to look out for. So I'll discuss the impacts, and then we'll consider how often you might be encountering victims and survivors in your day-to-day practice. And finally, reflect on practitioners and maternity services roles in supporting survivors to increase their safety and minimize the negative effects of abuse. Firstly, if we consider any woman victim of abuse, she is twice as likely to experience depression, 16% more likely to have a low birth weight baby. She is 42% likely to have experienced, 42% of women who have experienced physical or sexual violence at the hands of a partner have experienced injuries as a result. Abused women are twice as likely to have substance misuse disorders. And at this point, it's worthwhile considering the overlap between sexual and domestic abuse. So just looking at some data from England and Wales, for the year period ending in March 2020, the Crime Survey reported 618,000 women aged 16 years and above who had experienced sexual violence. 45% of these women had experienced that sexual assault at the hands of their partners. So a huge proportion of sexual violence is aggravated by domestic abuse. And this very much underpins the mechanism involved in the high rate of sexual health problems seen in domestic abuse victims. So just returning to that slide again, I wanted to point out seminal research by Jacqueline Campbell that you might be aware of from 2002, which identified gynecological and sexual health problems as the area of most pronounced difference between those that have and have not been exposed to intimate partner violence. Women with domestic abuse are 1.5 times more likely to acquire HIV, 1.5 times more likely to acquire syphilis, chlamydia, and gonorrhea. And then for the really hard-hitting statistic, and that is that 1 in 3 murders of women globally are committed by intimate partners. So we shift the lens now from women's experiences in general to the experiences of women during pregnancy, when not just 1, but 2 lives are at risk. The effects of intimate partner violence on maternal and neonatal outcomes are multifaceted. There's an increased odds of experiencing miscarriage and abortion for those experiencing domestic violence during pregnancy. A 2016 review drew together findings from 50 studies in just one meta-analysis and found that a nearly 2-fold increase in the odds of delivering a preterm infant among victims of domestic abuse during pregnancy compared to women who were not exposed. And in this slide, I just wanted to highlight some of the direct and indirect effects of violence on neonatal outcomes. And these include poor nutrition, poor weight gain, and substance misuse. Pregnant people may also experience delays in their maternity care due to being prevented from leaving the house or missing appointments due to injuries. Emerging evidence on the mechanisms by which abuse affects neonates considers the alteration of the hypothalamic pituitary adrenal axis, so the HPA axis, and resulting changes that you might see in hormones that affect low birth weight, small for gestational age infants, and of course preterm birth as well. So beyond pregnancy, then there are also issues to consider. There's the long-term negative impacts upon the baby's anxiety levels, along with their brain and behavioral development. It's not uncommon to see poor parental bonding and lower rates of breastfeeding. And research from Howard et al. In 2013 from the UK found a 3-fold increase in the odds of postnatal depression among people who had experienced domestic abuse. Now, to demonstrate this public health problem as widespread, you may be familiar with the World Health Organization's 1 in 3 statistic, which suggests that 1/3 of women across the globe have experienced physical or sexual violence from a partner. For approximately 1/3 of abused women, pregnancy was protective. That was a protective period, while for another group, around 15% of those abused during pregnancy, abuse started or it worsened during pregnancy. For the remaining proportion, the pattern of abuse remains pretty much consistent before, during, and after pregnancy. And I just wanted to draw your attention to the World Health Organization's multi-country study. Again, you might be familiar with this, but it shows a huge range in the prevalence of domestic abuse during pregnancy, from 1% in some parts of the world as high as up to 28%. And in fact, that's higher in some other parts of the world as well, I believe. So most studies are coming in around 3 to 9%, but there are well-established risk factors associated with high rates of abuse. So these include young age of the mother, single relationship status, poverty, and minority cultural and ethnic backgrounds. And I suggest to consider any characteristic of a person that places them in a minoritized group. And it's very positive that Sarah has already referred to the contribution of members of the traveller community and migrant women, and how this is being represented on the advisory group as well. So these are really important factors that will be brought up again in a little while. So now we take a moment to ask yourself about the potential for domestic abuse in the setting where you work. Is it on your radar to the extent that these other very valid health concerns are? So we're thinking 1 in every 10 birthing women or people is experiencing domestic abuse. This makes the problem as common as gestational diabetes and even more common than preeclampsia. So just a moment to reflect on that. Now, given the prevalence of and the severity of the problem of domestic abuse, alongside deeply complex barriers to disclosure and getting help, and we don't have so much time to look at that today, or at least I don't in my presentation, but it is reasonable to consider that asking all women about abuse, so that would be universal screening programs, would help to identify those experiencing abuse and enable immediate support and referral. So to this end, we conducted a Cochrane review and a meta-analysis on available research trials of screening interventions. We asked if screening increases identification and referral to support. The numbers and proportions of women identified were modest, actually, when considered against the estimated prevalence of domestic abuse among women across a range of different health settings. Okay, so very modest effects. And really, it was not possible for us to justify screening across healthcare settings based on these numbers. However, we did conclude that it may be equally or more effective to train healthcare professionals in effective case finding for IPV as part of the routine social history. So being aware of red flags, considering where women present with depression or sleep problems, for example, or obviously injuries. It may also be equally or more effective to ask women who show the signs of abuse and those in high-risk groups, and provide them with a supportive response, safety planning, and information. And this research was published, it was published in the BMJ, but originally it was a Cochrane review, and it was picked up across the pond in the US by the American College of Physicians, where it's been very instrumental in the debate around whether to screen or not, because the US, or the Center for Disease Control policy, is that all women should be asked about abuse, but obviously that contrasts with our own recommendation. So if not universal screening, if not asking everyone, perhaps it's selective screening. Now, our research has demonstrated that 57 more pregnant women per 1,000 are identified as victims of intimate partner violence by clinicians following a screening intervention. And the World Health Organization has adopted this evidence to underpin a global message that all pregnant women should be asked about abuse. So we're advocating not universal screening, but yes, the selective screening in high-risk groups such as antenatal care, maternity services. And this change for this was a shift for the World Health Organization from an earlier stance around only inquiring in response to certain clinical signs. So previously it was about case finding. So is selective screening or screening high-risk people for intimate partner violence the answer? Well, we see implementation of screening programs in maternity services across different health systems of the world, which is certainly a positive step, but that's not where it ends either. So just moving on to my next slide. And to illustrate my point, I'd like to draw on my own experience. So back in 2014, around the time I was extremely busy with publishing all this work, I was myself accessing maternity services in Ireland. And I have to say, I had a very positive pregnancy experience. And I often joke that the calm little 7-year-old boy that I have now started with that positive experience in birth. But I did have this notable experience along the way at my booking appointment, in fact. And the midwife was inquiring about my history, but when we came to the question about domestic abuse, she actually answered it for me. Well, that's not an issue for you, and continued on. She was kind and open, and we ended up having a good chat about how she had approached asking me about domestic abuse. And she shared with me that it made her feel uncomfortable asking about it. She agreed she had made assumptions about my level of risk, and it seemed domestic abuse had not featured to any great extent in her own training. And yet I thought 1 in every 10 women that sits in front of her is a unique opportunity to throw a lifeline. So I think it's really important to be aware, again, that just asking the question isn't the answer either. There need to be minimum conditions in place for healthcare providers to ask someone about abuse. It must be safe to do so. The World Health Organization, amongst its many different resources for supporting best practice in this area, highlights a list of minimum requirements for intimate partner violence care. So we're looking at a protocol or standard operating procedure, training on how to ask about partner abuse and how to provide the minimum response, a private setting, ensuring confidentiality, and also understanding the limits of confidentiality and being able to communicate that to your client or patient. There needs to be a system in place for referral and time to allow for appropriate disclosure. So lots of the different elements that Sarah has just made reference to in the Maternity Project. It's not the responsibility of staff to solve violence-related issues, address all violence-related needs, or to address all aspects of treatment, care, and support in one consultation. So this is a journey, and it is possibly why the maternity services is a good setting in which to inquire about domestic abuse, because of that continuity of care that takes place over a period of time. In terms of creating an environment for disclosure, well, it's vital that the maternity services environment is welcoming and promotes an atmosphere of empathy, warmth, and support. It needs to promote messages about the unacceptability of domestic and gender-based violence and where to get help. And it's advisable to display posters, pamphlets in waiting areas, consulting rooms, and in women-only spaces. Now, the lives approach is a helpful way to think about the ingredients for a best practice response. So we're just moving along now, thinking about, well, what sorts of resources are available to practitioners working in this area. The lives approach emphasizes active listening, inquiring about the woman or birthing person's needs and concerns, validating experiences, and avoiding any response that might make a person feel they've been judged, or anything that disempowers the individual, such as trying to convince them to go to the Gardaí or leave the relationship. Rather, you want to be able to explore the options collaboratively and demonstrate that you respect their wishes. These are really the hallmarks of a good practice response following disclosure of domestic abuse. And on this slide, we have a list of different types of potential negative provider behaviors and the consequences, potential consequences of these behaviors. So blaming and disrespecting the person could inflict additional emotional distress or trauma. Secondary victimization is always a risk when it comes to disclosure of domestic violence. It may be that the professional does not recognize DVA or domestic abuse behind the chronic or recurring conditions. This means that the woman can end up receiving inappropriate or inadequate care. There may be failure to provide post-rape care or address violence against women in family planning. And obviously we're talking about antenatal care here, but it can lead to unwanted pregnancies, STIs, HIV, unsafe abortion, harm to the unborn child, and more violence. We also need to be aware about breaching privacy or confidentiality and the risk of ignoring signs of fear or emotional distress. So if the woman has disclosed abuse and you have validated the person's experiences and difficulties, before the consultation comes to a close, it's really important that you check in with the person about their current level of safety and enhance their safety. So there can be an ambiguity around the notion of safety. People subjected to abuse may not perceive themselves to be necessarily unsafe. Running through some objective indicators will help to signal to you and to the person themselves if there is an imminent risk of harm. Is the abuse escalating? Has the perpetrator been physically violent during pregnancy? Has there been a rape or sexual assault? You might ask the person, have you been forced to do sexual things that you don't want to do? There may even have been threats to kill her, the children, the pets. Endorsing any of these behaviours will be a red flag and warrants clear and compassionate communication to help the person understand that they are at high risk of serious injury or harm. It requires making a safety plan and providing immediate and accessible options for safe accommodation. Now, this could be a family member or a friend, or it could involve making a referral to a refuge. So in preparation for making a safety plan, you could say, you can't stop your partner's abuse, only he or she can do that. However, here are some things that you can do to plan for your own and your children's safety. You can make it clear that that could be inside the relationship, or it could be in relation to leaving. You could point out you're probably already doing some of these things, so recognizing her strengths. You're probably doing some of these things to protect yourself and your unborn child or your other children. Here are some things you can do. So then that's where you can make the safety plan with somebody. In terms of support and referral, women are at increased risk of domestic abuse if they have a disability or a chronic illness, if they live in poverty or social housing, if they identify as gender diverse, and as we've mentioned previously, if they come from a traveller or migrant background. When these identities overlap, the risk can be compounded and the barriers to escaping abuse are even greater. So this is really speaking to the third point on the slide, that we must ensure equitable care for all survivors of domestic abuse. And it's important because people with minority characteristics may present to maternity settings when they've already been subjected to discrimination, or they have fears about how they're going to be treated, or that they'll be treated differently. And getting help in domestic abuse can seem almost impossible to access. So I just wanted to make the point again that in the context of referral for domestic abuse, people's protected characteristics should be taken into account, and in collaboration with the person, identify the resources and the agencies that are likely to be most helpful to them. And then in terms of follow-ups, another part of the LIVES approach, thinking about support and follow-up, arranging for follow-up is an important part of this process. It can be a lifeline. Pregnancy journeys open up opportunities for providing support over time, and it gives the person the tools and the space to increase their awareness, or can do this at least, if it's done right. The impacts, that can increase their awareness of the impacts of the abuse on them and their developing baby, and it's these important connections that can help increase a person's readiness for making changes in their lives. A follow-up allows them to explore their options for support within their own family or social network, and to access more formal support. But in the meantime, providers should ensure that pregnant people are equipped with the 24/7 helpline numbers, and they know how to keep themselves safe if their partner or another family member becomes abusive. So it's very much about equipping people with information, empowering them to make their own choices. They can explore what to do in between appointments. They need to know how to be safe. And so now for my concluding remarks, I just want to again really emphasize the point that domestic abuse is a serious public health problem. It has substantial negative effects for women and birthing people, for babies, and also for offenders. It's another aspect to consider. Selective screening in maternity services is recommended when certain conditions are present. Listen, inquire, validate, enhance safety, provide support and follow-up. The LIVES approach is a stepping stone to good practice. Effective care for domestic abuse also requires systems-wide recognition and responses to enable staff to be adequately prepared and supported to deliver this crucial part of their work. This includes recognizing that men and women working in health services may themselves carry their own trauma from interpersonal abuse. This may be ongoing abuse, or it may be non-recent. But there is certainly evidence to suggest that this can impinge on their own capacities to support their clients and patients. In this sense, hospitals also need to have pathways for staff. Domestic abuse is a preventable problem. Let's work to eradicate it together. If you would like to access our free training, a little plug I'm going to make before we finish, we have an open course available at Coventry University, and it's accessible on an ongoing basis. And Sally, who will be speaking with us later, joining the panel, is the course director for that course. And also I wanted to share the link for the WHO resources and online training. And finally, just a massive thank you for your time this morning. And it's been a great pleasure sharing about the research in this area. Please do get in touch if you're interested in any of the papers or resources that we've presented. Thank you.
Thank you so much, Lorna. There was so much in that, and I love the balance of the research base with that kind of practical tips and feedback that are very much around the actual practice, and you know, that concluding kind of the concept of lives as a phrase to kind of help kind of remind people of some of the simple things that can be just so effective. So thank you for that, and of course for sharing the training and the other resources. I know they're always appreciated. So next up, we have Dr. Siobán O Brien Green. Siobhan has worked in government agencies and the non-profit research and academic sectors for over 20 years. Siobhan has worked on multiple national and European multi-country gender-based violence research projects. She's taught, published and presented widely on issues of gender-based violence, female genital mutilation, designing and undertaking research with vulnerable populations. And her PhD research explored help and safety seeking by women who have experienced domestic violence during pregnancy in Ireland. Siobhan has contributed to the Health Service Executive National Domestic Sexual and Gender-Based Violence Training Resource Manual, which is called Recognising and Responding to Victims of Domestic Sexual and Gender-Based Violence in Vulnerable or At-Risk Communities in 2019. And she has also been appointed to the advisory group of the Study on Familicide and Domestic Homicide Reviews commissioned by the Department of Justice and Equality. So today we're delighted to welcome Siobhan, who's going to present on pregnancy and domestic violence, findings from recent Irish research. Siobhan, you're very, very welcome today.
Thanks, Sarah, for the kind introduction. I'm delighted to be here. So I'll just start sharing my presentation. And my video is off now as well too. So I'm delighted to be here and delighted to follow Lorna's excellent presentation as well too. And I think we'll see some common themes and issues emerging through the two of them. So today I'm going to talk a bit about domestic violence and pregnancy in Ireland, what we know about it in terms of prevalence. I'm going to talk about my research study and findings from my PhD funded study on women's routes to seeking help, safety and support in relation to domestic violence and pregnancy, and then recommendations and implications of the research for maternity care in Ireland. Of course, this work is very much framed in terms of our international policy context, which we've adopted in Ireland to the United Nations Sustainable Development Goals. And our focus during the 16 days of action is very much around goal 5 in eliminating all forms of violence against women. But the issue of domestic violence and pregnancy significantly overlaps. And we can see that from Lorna's presentation on the good health and well-being goal 3, and of course on peace, justice and strong institutions goal 16 as well too. Our own policy context for maternity care has really changed quite substantially in the last number of years as well too, probably commencing with Ireland joining our colleagues in United Kingdom and the confidential maternal death inquiry data. We have the MDE unit based out of UCC and CUMH. Our first ever national strategy on maternity care launched in 2016, and then the subsequent HICWA guidelines as well too that emerged after the strategy that informs our maternity care provision. And of course, our legislative changes have also happened in 2018. Domestic violence legislation specifically talks about pregnancy as a factor for courts to consider in terms of applications to it. So in terms of the outcomes of domestic violence and pregnancy, I think Lorna has covered them all. That's a one slide recap of the WHO research really, but we have to say obviously they're fatal and non-fatal outcomes and incredibly serious for both mother and baby. In terms of domestic violence and pregnancy prevalence in Ireland, there's a number of research studies I drew on when I started my PhD research, and the Rotunda Hospital one by O'Donnell et al. is probably the one that many of you would be familiar in terms of the number of women, or the 12% of women, or 1 in 8 women responding to that piece of research stating they'd experienced domestic violence during a pregnancy. Indeed, the later research, the Watson and Parsons ESRI research that interviewed men and women across the country, stated that 7% of those interviewed had felt that pregnancy was a trigger for abusive behaviour in their relationships. And another piece of research undertaken by Safe Ireland, which I was one of the study leads on, interviewed women, 40 women across the country, and over 62% of respondents said that their partner had abused them physically while they were pregnant. Fundamental Rights Agency Violence Against Women survey from 2014 is the largest study of its kind and is the most recent data we have that's nationally representative on violence against women in Ireland. And indeed, I'm sure many of you are familiar with the study. When I started my PhD research, I got access to the 42,000 women data set and did some additional data mining and extrapolations into it. Now, it had a very high survey response rate, 48% of respondents. That's almost 1 in 2 women who were asked to participate in the face-to-face interviews took place, which is very high. And we also noted that 77% of the Irish survey sample had children as well. So if women who were taking part in this study had reported experiencing domestic abuse, domestic violence, they were asked in addition, have you ever been pregnant during your relationship with your current or previous partner? And then they were presented with this show card. So they were asked if any of these violent incidents or acts had happened to them as well too. And I think when we think about what Lorna has just described in terms of red flags, high risk, these are very serious instances of violence when somebody is pregnant. So women responded either yes or no. They didn't identify which of these had happened, but I think all of us need to be concerned that this is what women were reporting experiencing during pregnancy with a current or previous partner in the Irish sample. When we look at that in terms of statistics, we can see that basically 4% of the Irish survey sample had experienced violence during a pregnancy, and 2% of women in Ireland had reported a miscarriage as a result of the most serious instance of domestic violence or sexual violence. We also are above the EU average in terms of women experiencing violence during a pregnancy in this study sample. So although the numbers are low in terms of overall figures and not necessarily statistically significant, we are above average for both current and previous partners in terms of experiencing domestic violence during a pregnancy. And I think that gives us a stronger rationale to continue and enhance the work in this area. So on to my, and the FRA study findings as well, in terms of where women reported and went to in terms of experiencing domestic violence. I think most of us know that shame, stigma, and embarrassment were significant reasons for women not to report. Women mostly dealt with themselves, but importantly for our presentation today, about a quarter of women went to their GP or to another healthcare professional about the violence that they were experiencing. In terms of my own research, now the PhD research study is a qualitative piece of research, and I felt at this point we knew that women were experiencing domestic violence during pregnancy and the severe ramifications of it. But really, my interest was in terms of what enabled women to seek safety and sought help, and that really went back to the very first day when I started work on a women's aid project in a women's refuge in Dublin in 1998, and one of the first women I met was pregnant, and I thought, what has enabled that woman to get to that point of safety and protection? And how can we do more of it to enhance this for women across Ireland experiencing violence during pregnancy? So it was granted ethical approval by Trinity College, which also gave me a scholarship to do the research. I interviewed 18 women across Ireland with a range of ethnicities, nationalities, a range of ages, range in the number of children as well too. 2 women were actually pregnant during the interviews as well. There was quite a substantial part of the survey study sample that had moved to Ireland over migrant women as well too, who'd lived in Ireland for various lengths of time. Women who had different jobs or were studying as well too. And I think most interesting for today is that out of the women who gave birth in Ireland in the study, which is 17 out of 18 of those studies, they had used 10 out of the 19 maternity hospitals or units. So that's a very broad range of service utilization they could speak to and give their experiences as well too. I have to say it was challenging to recruit women to take part in the study as well. There is an overrepresentation of migrant women in the study sample, but we know in terms of the Healthcare Pricing Office and HSE figures that about a quarter of women in any given year over the last 7 years who give birth in Ireland are migrant women who've moved here as well too. And we've also seen in previous research by the Women's Health Council and by TUSLA, there's an overrepresentation of women in domestic violence settings as well too. I think most importantly for us to keep in mind is that the women who took part in my study had both migrant male partners and husbands and Irish male partners. So they might have come here because of getting married to an Irish man, and that was their reason for actually coming to Ireland. I didn't ask any of the women I interviewed about their experiences of domestic violence because I felt that that had already been quantified in some way through the FRA study and through other studies, Watson and Parsons and other pieces of research, making the links as well too. But all the women I spoke to described the experiences they'd had of domestic violence, including emotional, verbal, physical, financial, sexual and physical abuse as well too. No women interviewed reported the domestic violence ending once their baby was born. And 2 women reported that their pregnancies were actually as a result of rape within their relationships as well too. For all the women in the study, there's a point in time that the actual experience, the lived experience of the abuse and violence they were going through became unmanageable, and their hope for a change in the situation, their partner's behavior left. So really women could no longer manage what they were living through as well too. And I think this is the absolutely critical and crucial point. And Lorna spoke about pregnancy being a kind of a turning point for a lot of women as well too. Recognizing and responding to this point is really crucial in the maternity care setting. So in terms of the research study findings, I'm just going to, there was a number of themes that came up, which I'll speak to all briefly. So keeping the woman at the center of the research was crucial for me. Talking about finding services supports, women's health, which emerged strongly as a study theme, children, social workers are a sub-theme of this section. And really, what are the inhibitors to women finding services? And are they slightly different for migrant women interviewed? How are they interconnected and act as barriers in terms of help seeking and safety seeking? And what are the enablers for women to seek safety support? Using domestic violence emerged strongly as a positive enabler. And how can we do more of these in our healthcare settings in Ireland? The finding services, women had multiple routes to finding services and information. And in most cases, the women I interviewed, they self-referred to domestic violence services. Women looked online. Sometimes friends helped them as well as sources of information as well too. And despite them attending for their maternity antenatal appointments, GPs, and maternity units or pregnancies, the actual healthcare services they were interacting had a very minimal role in terms of finding and accessing specialist domestic violence services. And this might be possible because 3 women recalled actually being screened or questioned about domestic violence during their pregnancies. Women's health became a strong emerging topic as well too. And after my first interview, I added in a question to my interview schedule. And women really, when I asked them, how was your health during your pregnancy? I wasn't looking at their medical records or files, but they recalled really challenging health issues that really they connected to the lived experience of being in an abusive, violent relationship as well too. Some of them were very serious and meant longer or repeated stays in hospital, or even returning. One woman was returned to hospital in an ambulance a couple of days after giving birth and being discharged as well too. So for this research sample, they had more, not less, contacts with health services during their pregnancy because of these issues. Mental health as well too. Women described needing to get out. One woman said, please, my life is over. I don't want to live anymore. It's over. Women described feeling like they were losing their minds as well too. And one woman in the study sample had attempted suicide. And we know from the maternal death inquiry reports that suicide is a leading cause of direct maternal death for different trienniums reported on as well too. But there was really little exploration of women's presentations of depression, anxiety and suicide in the women I interviewed and spoke to despite these presentations and concerns. So women's children were a major study theme as well too. So women feared for their own safety, but really the safety of their children. And we know that domestic violence perpetrators, the threat of women having their children removed from them by social workers or social care services as a reason to keep women in a violent and abusive relationship. And this is certainly recorded in the interviews that took place for this study as well too. Women, some in the study already had children in foster care as well too, but also women felt that the safety of their children, their future, the life ahead of them was a really key reason to keep on looking for help, looking for safety and seeking the supports that they needed as well too. And a number of women did report that their interactions with social workers were enabling and helpful. In terms of overall inhibitors that women recorded, shame and stigma was a very significant one. And we think back to the FRA study, Violence Against Women survey data, and that was significant for the Irish sample as well too. Women not being asked or not being screened about domestic violence during their pregnancy, antenatal and postnatal medical visits seemed to reinforce the shame and stigma actually. And a lack of information, women could not recall, most of the women, 14 in the sample, could not recall seeing information about domestic violence or any support services in the healthcare settings they were engaging with for their maternity care. Women also spoke about the challenges of finding housing. And for the migrant women, as part of the study, they were not necessarily familiar with how services worked in Ireland. How would you access them if you had to pay for them? There were language and isolation challenges for them, and most of them had no family support in Ireland. In terms of the enablers, which I was really keen to understand and get to in this research, they were both internal and external to the women interviewed, which they identified. So women really drew on their inner strength, that need and motivation for change and safety, and a real heightened vision for a different life for them and their children away from violence and abuse. Women were incredibly resourceful and found support and information around domestic violence from a very wide range of services and professionals. And every time, no matter if it's from your work manager, a taxi driver, a priest, a school principal, getting a positive, supportive response for the women interviewed was incredibly enabling. And when women were actually linked in and connected with specialist domestic violence services, their experiences were overwhelmingly positive. There might be, however, some study sample recruitment bias in this study. So in a nutshell, the study findings really are stigma and shame are a very significant barrier to help and safety seeking, especially for Irish women. The lack of screening and information in the maternal healthcare settings that women were using above and beyond normal and regular routine antenatal care because of their presentations and because of their healthcare challenges seemed to reinforce the challenges to finding help and safety, but also the stigma and shame. Any kind of positive or professional service interaction allowed women and supported them in moving forward and indeed more help and safety seeking. And when women are referred into specialist services as well, too, especially migrant women, they were very satisfied with the care, support, advice that they got. In terms of the recommendations, An obvious one really is the repeated screening for domestic violence in all maternity healthcare sessions, at least once as well, making, as Lorna described, disclosure-friendly settings with information available. It might need to be in multilingual, given the diversity of women using our maternity care services, and really putting the patient first, treating the patient, not the symptoms, not making the assumption that women experience in this study that the symptoms are caused by pregnancy and not by the violence and abuse a woman's living with. We need to avoid the cycle of disillusion that Evans and Federer decide, where women are attending healthcare professionals in relation to what they feel are the problems and healthcare challenges linked to their abuse, but they're not receiving appropriate responses. And we have a great potential in our own with our 19 maternity hospitals and units to link closely and work closely with the domestic violence frontline services, in particular the 21 refuges. We know from a range of research, including Lorna's there, that there's an acceptability screening for domestic violence amongst the Irish studies, Bradley's, McDonald's, and indeed the Fundamental Rights Agency. Almost 90% of the Irish sample said that it was a good thing for doctors to ask about domestic violence when they see people. And HICWA mandates us to screen as part of our antenatal social care setting. We also know from the Saving Lives, Improving Mothers' Care Embrace report that has a special focus on domestic homicides in 2015. If we want to save women's lives, we need to be alert and aware to the signs and symptoms of domestic violence. We need to be aware of the care once domestic abuse is disclosed, and we need to be displaying clearly information for patients using these services. Each of you has a really crucial role in terms of identifying, responding, and referring women in relation to domestic violence and pregnancy. We have a crucial role where I work in Trinity in terms of the training of the next generation, the next cohorts of health and social care professionals, and the ongoing training and continual professional development around a range of professionals' needs, including legal, social care, social work, medics, midwives, around domestic violence and pregnancy. And just to let you know, there's a range of recent publications as well too, rising from the research. This month's WIN, I have an article on domestic violence and pregnancy. And in this time last year, I did an article for the Form GP journal as well, to short and snappy research pieces that might help you and your colleagues in terms of your work in this area. So thank you very much for the invitation to present today. It's been an absolute pleasure to be here to share my research with all of you. And thank you for the invitation from Women's Aid.
Thank you so much, Siobhan. Again, there's so much in there. Really interesting observations just in terms of where there's compound health issues that might actually present even greater opportunities rather than the assumption of a late presentation. And of course, recognizing as well, like the role of GPs, you know, we're aware of that, and historically Women's Aid would have done some work with the training side of things. But again, I think part of what our pilot will show is just how a whole community, both inside and outside the health sector, is just absolutely vital. And we do know that that stigma and shame, we are aware of it ourselves in Women's Aid and the specialist support services, and that doesn't come from nowhere. It's being mirrored back at those who are victims and survivors. And so this kind of coming together is all the more important to make sure that we are giving a different message, and one that's of invitation to disclose and to be offered support without stigmatization. So thank you again. So for our next speaker, I'm delighted to introduce Gillian Dennehy, who is the Maternity Project Co-ordinator at Women's Aid. Gillian's previous role with Women's Aid was as the service manager, overseeing the crucial face-to-face frontline services. And prior to that, Gillian has worked for various nonprofits in the violence against women and girls sector for over 13 years. And this has included many direct frontline roles in London, such as an independent domestic violence advocate, or IDVA, in the criminal courts. She also has a wealth of domestic abuse training experience in both Ireland and the UK, training diverse ranges of professionals, including Gardaí, police, hospital A&E staff, social workers, and the UK police on coercive control for organisations like Safe Lives. And she also worked as a domestic homicide review manager for the excellent organisation Standing Together in the UK. So Standing Together Against Domestic Abuse. and was also a member of the UK Home Office National Domestic Homicide Review Quality Assurance Panel, approving DHRs for publication. So Gillian's input today is going to be to give an overview of particularly the current awareness campaign that we're running with our partners as part of our pilot with the maternity hospitals, and some other key developments with the project to date. Thanks, Gillian.
Thanks, Sarah, and thanks to all the speakers. It's been great so far, loving it. So yeah, I'll just share my screen now. Okay, so, skip me on. So hello everybody. Yeah, I'm going to be sharing the story so far. So basically what has been happening since I guess the project started in May, but I joined in June. So what have we been up to? And one of the key things we've been up to, and I hope you've seen things around the hospitals, and also you've seen things on social media. We've been doing a 16-day awareness campaign, and this is really to raise awareness to staff and women in the hospital. And so included in this is some physical assets such as posters. So I'm just going to go through some of the assets that we used for this campaign. And this, I just supposed to really emphasize, this is was a real collaborative effort of the partnership, including all the 4 leading hospitals. There was a lot of emails and phone calls, and we got there, and I hope you think that they were worth our time and effort. So this poster is directed at staff. It is basically, again, using that, what we've heard a lot from Siobhan and Dr. Lorna O'Doherty is that domestic violence and pregnancy, domestic violence and abuse in pregnancy is more common than you think. We really want to get that simple message out there, because we believe, that's not known enough by the general public and by staff in maternity hospitals. And also to kind of say, okay, look, it's common, but what do you do when a woman discloses domestic abuse? And that key thing is to refer to the hospital's medical social work teams. The hospitals are very lucky; they have very good social work teams who are experts in their own right on domestic abuse in maternity care, and so we're really just trying to direct staff towards those that expertise. And it's also, of course, to raise awareness of the National Domestic Abuse National Helpline, which is 24 hours, 7 days a week, and just there we have the tagline at the end as well, that we're working in partnership to listen, believe, and support women. And again, this is all about, as Siobhan mentioned as well, it's all about, and Dr. Lorna O'Doherty, that it's all about, dispelling that shame. It's about creating that environment for disclosure. And also it notes that staff can be victims of abuse too, and that there is support for them there. So we have there like a shocking statistic from the UK Royal College of Midwives that found a survey that found that 82% of midwives and maternity support workers had experienced domestic abuse in their working lifetime. And we will have the excellent Dr. Sally Pizarro joining our panel, and she was actually involved in that survey research, one of the authors, in fact. So it's great to have her to join us to talk about that survey. So the next poster was directed specifically at women. So we have this poster, anyway, it's about, the common signs of domestic abuse, but we tailored this for women experiencing domestic abuse in pregnancy. Again, wanting to share that key message that domestic abuse in pregnancy is common, you're not alone, and it can be high risk. It's important for women to know that. And I just point out some of the signs there, that one of the signs is they control your access to basic essentials such as the car, family finances, food, the telephone, internet, and healthcare appointments. So, we were adding in, things like healthcare appointments, because one of the key impacts of domestic abuse during pregnancy, as already mentioned, is that women's access to their antenatal care can be inhibited by abusers, and often attendance can be quite late in the pregnancy. Also, what you see number 9 there, we have they're physically violent to you, and often the assaults are aimed at your abdomen. So again, we wanted to just bring that in to just say, look, as was mentioned already, that, there's a lot of shame and stigma around experiencing domestic abuse. I wanted to say, look, we know this might be happening to you and you're not alone. And the key message there, we're here to support you. You can talk to a member of hospital staff. So again, creating that environment of disclosure. And that would be in waiting areas for women, on the back of toilet doors, etc. then we always do Women's Aid, we always do 16 facts for 16 days. And the maternity hospital staff were like, look, why don't we, do one pregnancy specific? And we were like, yes, let's do it. And so we created this together. So one of the, again, some of the key messages there, domestic abuse does not stop in pregnancy. Often, people think that it is, pregnancy is a protective time, but we want to say, look, no, it doesn't stop in pregnancy. And in fact, it can intensify, it can escalate. And here are some of the impacts. So again, Lorna mentioned a lot of these impacts. And so, just again, creating that awareness for both women and staff on the issue. If you see there, one of the stats there is 148 women reported abuse during pregnancy to Women's Aid last year. And of course, they're the women who are disclosing. We know many women might not disclose that because of the shame and about disclosure about that. Then the next resource here this is actually a detailed resource on specific signs of domestic abuse in pregnant women, providing staff with information on the key warning signs they can look out for. So we took this from the 7th report on confidential inquiries into maternal deaths in the UK, the 2007 report, authored by Gwyneth Lewis. And in that report, there was 19 women who were murdered. And when she looked at those cases, she was like, well, actually, there's a lot of signs and indicators here that were missed, unfortunately, by the maternity care staff in the hospital and the different healthcare professionals the women met along the way. And some of those signs were such as unexplained admissions to A&E, repeat attendances at the GP surgeries, emergency departments, again, like late bookings or non-attendance at antenatal clinics. For example, the woman appearing evasive or reluctant to speak or disagree in front of her partner, a partner insisting and acting as the translator for a pregnant woman for whom English is not their first language. And again, we're just, want to give this as a resource to staff to say, look out for these signs. If you're concerned, speak to your hospital's medical social work team. You can call Women's Aid. The helpline's there for professionals and women experiencing abuse. And it's there 24/7, 7 days a week. And again, that to say that, again, we're working in partnership to support staff around this. And the last bit is the pull-up sign. And I'll actually just go to the post, I'll show some photos in it to show this pull-up in action. So this sign was just basically to grab people's attention. It'll be in the entrances to the staff. And it's about, again, domestic abuse and violence and abuse in pregnancy is more common than you think. So here then is some social media posts. So we have the physical assets, but we also have the social media assets that we've used. So here are some tweets. You see myself retweeting these. So that was one of the first posts that we have tweeted for the partnership, that we're working in partnership to listen, believe, and support women experiencing domestic abuse. And we will keep repeating that because that's really the essence of this partnership, to say, we are here, we're here to support you, we will believe you. And so women, for women not to feel ashamed to disclose, for women not to feel isolated, that support is there. Again, more totes. So some photos of the things in action. So we have here from the National Maternity Hospital. We have the Rotunda. You see there that the pull-ups at the entrance to the doorway, Cork University Hospital, University Hospital Kerry, and the Coombe. So just going on to the second strand of the project, which is training. So training obviously is the key strand of the project. And I've spent a lot of time since June building relationships with the key leading hospitals of the project. And again, thank you to them for their great commitment to this project. We can't do it alone. That's what it's all about, working in partnership to respond to domestic abuse. And what we're doing is establishing internal hospital committees in each of the 4 leading hospitals, and those internal committees will be looking at, okay, well, what is it that we want to learn? What is the key things the staff need to learn about domestic violence and abuse? How do we ensure they learn this, like what are the best mediums? Is it e-learning? Is it, online, learning like for a few hours? Is it face-to-face learning? What is going to work here and what will we try out? So then we will develop the training material, get it signed off by all the 4 leading hospitals, and then pilot that training in with sample staff in hospitals, in the 4 leading hospitals, and also in regional hospitals that are connected to those hospitals. And then of course evaluate. That is the key part as well, where we are in the process of recruiting an evaluator to independently evaluate this, because we want this to last. We want this training to be embedded in the hospitals and to last beyond the 3 years of this project, and to have the impact of increasing staff's confidence in responding to domestic violence and abuse. The third strand of the project is the referral strand, and with the referral strand, it is unique because we have a named worker, the excellent Ciara Kenny, who's very, very experienced, who is there for hospital staff to consult on cases and refer. And this is unique, it's unique to Ireland because she only accepts referrals from the maternity hospitals. She's linked with the 3 Dublin maternity hospitals. And the service is for maternity care patients and maternity care staff. So for both, because we recognise that 1 in 4 women in Ireland experience domestic abuse. So of course there's hospital staff that experience abuse as well. And so we want to be there for them as well. And this outreach support as well is all about responding promptly to immediate needs. It's crisis support. So for example, those practical needs, like the woman needs a refuge, supporting her to access refuge space. There might have been a recent assault, supporting the woman on advocating to the Gardaí for support and protection, accessing the court and accompanying women to court to access emergency protection orders. So Ciara's, done all these things with women, and it's a vital support for women experiencing domestic abuse. The key aspect of this project is, Siobhan has, research was crucial to this, is that, as well as that, she was saying that, women took a long while trying to find the specialist support that they needed in the community. And we want to take away that time spent for women spending, looking and searching for service, and say, look, we're here, we're accessible, we're there for you. And really it's based on as well, UK models in the UK where domestic abuse workers are co-located in hospital settings, in police stations, and working alongside these professionals. And we have research that tells us actually that domestic abuse support workers that are co-located in hospital settings, that the women who access the support from these workers have experienced abuse for an average of 6 fewer months than survivors engaged with a local community-based service. So that's an amazing statistic, so it just shows that accessibility and that prompt access when the service is brought to survivors. So just to go through a case study. So, one of the women that Ciara worked with was experiencing severe coercive control. She was experiencing severe physical abuse, the abuse of course during pregnancy. She was in the beginning of her 3rd trimester. The abuser targeted her abdomen with physical assaults and used items also by throwing items to harm her. She had tried to separate from him and asked him to leave. He refused to leave the home, and in fact, took the keys away and effectively was, trapping her in the home. She was successfully referred by hospital staff to the medical social work team, who then referred her into Ciara, our outreach maternity support worker. And there was successful support engagement with this woman. Ciara supported this woman to access an emergency barring order, and then went on to support her to access a 1-year barring order. And that meant that the abuser was effectively prohibited from coming near the woman and also coming near the home that she lived in. We also supported the woman through our Women's Aid Security Fund to change her locks. This is just a practical measure, but the woman did not have the money to do this and needed that support to get that support, to have her locks changed. And that was vital to make her feel safe in her own home. In addition, she was also very worried, concerned about the pending arrival of her baby. And because of all the crisis that was going on because of the abuse, she was she needed some, practical support and needed money to buy things for her baby, such as, you know, prams and Moses baskets. Anyone who's had a baby knows how much things a new baby needs when they arrive. And so we were able to do that through our emergency needs fund. In addition, this woman was identified, of course, as high risk. This abuser displayed severe coercive controlling behaviours, and we deemed her high risk. And so we were able to refer her into our high risk support project. This is a partnership between Women's Aid, the Gardaí and Vodafone Foundation. And this means she was able to access a prompt response from the Gardaí, ongoing monitoring of her safety and protection from the abuser, and also prioritising her address for emergency calls. So it just really shows the effective work of the project and all partners involved. The outcome for this, of course, this is the outcome we want for all the women. This is what we're talking about women, you know, enjoying their time with their baby. You know, she had her baby. They're now, you know, safe and happy together and free from abuse. And this is what we want for all women experiencing pregnancy. Shouldn't every woman have this opportunity? And, you know, there I have, you know, many different women in these images. And I suppose really what I want to say with this message as well is that this project is for every woman. And as Sarah mentioned, we are, you know, getting guidance and support from the experts in the NGO field to support us to make sure that we are making the project accessible to every woman. So for example, we have Pavi Point, an external advisory group, and we also have Corja, who are a non-profit working with ethnic minority communities to end health inequalities. And in addition, we will be reaching out to other, you know, great partners in the community, such as Amal Women's Group, which I just want to mention, who did a great recent research published, A Mother is Born Too. And that sadly showed how isolated Muslim mothers can be. And that, you know, with the late, in particular, they noticed one of the findings was late attendance of maternity care. And in fact, some women not accessing antenatal care at all until the final moment of giving birth. So, you know, really, you know, again, this project is for every woman, to give every woman the opportunity to enjoy that time with their baby. I just want to go through the services that Women's Aid offer, and I'm conscious of the time there, so I'll just be brief with this. This is really, look, there's many professionals listening to this. This Women's Aid helpline is for you as well. As a professional, you can call this helpline and seek advice and support around, okay, look, I'm working this woman, she's come in there, what's the, you know, what are the options for this woman? We can link you to specialist domestic violence services around the country. We're there 24 hours a day, 7 days a week, 1-800-341-900. If you come away with anything today, come away with this number for you and for women and for other women in your life as well that might need it. We have a language line, so we can access up to 171 languages. You call the helpline and we'll be able to access that language line for you. We have a tech service facility for deaf and hard of hearing women, 087-959-7980, which is open 8 to 8 every day, 7 days a week as well. In addition, we also have our instant messaging support service. A lot of women, you know, nowadays, you know, we mightn't always want to pick up the phone to talk. So we have this available for women who might not want to do that. Just access that on www.womensaid.ie and www.2into.ie. That's available morning and evenings. And, you know, as well as on 2into, just to mention that we do have like a quiz, that interactive quiz that you can take that shows you the signs of domestic abuse, and also tips if, you know, if a friend is experiencing abuse, what you can do to help. It's a really, really great resource. So please log on, you know, get onto those websites and see what supports are there for you. So thank you very much. And thanks again to all our great partners in this project. Couldn't do this without you. Thank you.
Thanks, Gillian. And thanks to everybody. I'd like to invite all of our speakers to turn your videos back on now, and also like to welcome Dr. Sally Pizarro, who's a fellow of the Royal College of Midwives and author of the Royal College of Midwives report and recommendations on workplace support for midwives experiencing domestic abuse. In 2021, Dr. Pizarro won the Partnership Working Award from the Royal College of Midwives and a Midwives Award from the, I'm going to pronounce this incorrectly, Olanthe Midwife Trust. In 2019, Dr. Pizarro was honoured with a first prize award from the Royal Society of Medicine in leading and inspiring excellence in maternity care, and was also the first runner-up for the British Journal of Midwifery's Midwife of the Year in 2019. You're very, very welcome, Dr. Pizarro, Sally. So we've had many questions come in, quite a few of which have been answered just through the natural course of either people's presentations or live in the chat, and my colleague on who's looking after our Facebook feed likewise. I wonder, and just with the time we have left, I just want to make sure and ask each of you to a specific question, just to draw out some of the interest that's coming from the audience. Sally, I might start with you because we haven't heard from you before, and your particular area of interest is something that has been flagged both in Lorna and Gillian's presentations, which is the actual prevalence among healthcare professionals themselves, obviously particularly female healthcare professionals, of domestic abuse. And I'm wondering if you could just share a little bit about some of your insights as to what are good examples of a supportive environment where not only are you a frontline responder, but you yourself might actually be experiencing abuse at the hands of a current or former partner.
Thank you very much for having me. Yeah, it was really interesting when we did the report and we looked at the findings as to what people were saying. Obviously, midwifery is a very female-dominated profession, and so we're human like everybody else. And a lot of maternity services, a lot of health services, really focus on the patient and not always the staff. So it was really interesting to say, actually, how do you experience this? Sometimes, how is it affecting your work and your life? With the midwives that were actually providing care. And as we've heard in the discussions before, it's so important to have positive responses to disclosure and asking the right questions, etc. But how does that work when the midwife asking the questions and responding to the disclosure either has experience themselves or has no experience themselves? And what was interesting was a lot of the time midwives were saying, I didn't recognize it in myself when it was happening to me. So you're asking them to recognize it in other people and potentially do selective screening or potentially identify people at risk, and they've not necessarily been able to identify it in themselves. And we've Lorna and I have put in a really powerful story in the online course we've co-created together of a midwife's experience in doing that. But really, what we'd like to see in hospital trusts and places where midwives work is policies and training which help midwives to recognise domestic violence and abuse in their colleagues, in themselves, and be supportive of that. Flexible working policies, for example, would help with people needing to be at home or be away from home at certain times. And then the IDFAs there for patients are there for staff as well to access. That would be a really kind of positive experience for people. And just recognising really that midwives are just as vulnerable, if not more so, because they give the service rather than receive the service to domestic violence and abuse, and really having an awareness of that. So we're really hoping that the training we've put in place and more training that's coming out will be able to highlight those concerns. And when I look at the course and I see people's comments, it's really interesting to see people's light bulb moments occurring when they're thinking, yes, that's exactly it. That's how I ask the question. That's how I reflect on my own experiences. So I was really glad to be able to publish this with the Royal College of Midwives to sort of put the light on maternity staff as well as the service users.
Okay, thank you. And just to acknowledge also, there's been some really positive feedback. Obviously, some of our audience today have already participated in that course. And while we will be sharing the recordings afterwards, Lorna or Sally, if you have the wherewithal to literally drop the live links into the Q&A. I know some people would like to just grab them now rather than have to wait and type out the URL. So please just encourage you to do that. Also to make audience aware, if there's anyone at the kind of human resource management or employer level watching at Women's Aid, have also recently enhanced our resources through our training department specifically to engage with employers on developing and rolling out through supported training domestic violence policies for their staff, which includes things like how to take the disclosures, managing kind of risk assessment and safety, as well as supportive leave policies. So if that's something anyone's interested in, they can contact our training unit about that in terms of a model policy and some support. Perhaps Lorna, just to move to you in terms of, you know, the comprehensive work you've been doing, and if this is something you're familiar with, the concept of clinical champions came up through some of the comments in the chat, and I wonder, just for those who might not be familiar, could you say a little bit about what that model is and some examples of how that might work well in practice, something perhaps we could consider here, or perhaps has been piloted here as well, just to acknowledge if I'm not aware, but yes, yeah, the idea of clinical champions.
Sure. Where we've seen this work particularly well is within the IRIS program in the UK. So this is the primary care training of professionals, but embedding within primary care and general practice a domestic violence support worker. But I believe as part of that program, they also have a champion within the practice, and that is often not the domestic violence work, but rather another professional, perhaps it's a GP, one of the GP leads, who can sort of really emphasize the importance of getting on board with the IRIS program and supporting survivors who are attending primary care at that practice. So it's certainly another important thread of work that can be added to, you know, the various other initiatives that are ongoing. And I just really want to applaud Women's Aid on this. This is an incredible project you're doing, Gillian. Well done. Just the connections that you're making with the various organizations. You mentioned Corjan, the AML organization, and earlier, Sarah, you referred to investment in greater connections. And I just think it's so much about that. I have to say, based on my own experience of conducting research in domestic violence and sexual violence, it is so much about the partnerships that you can, you know, that you create in the delivery of the work. Also, what I mentioned in my own presentation was the importance of the systems-wide approach, you know, engaging the hospitals at all levels. So it also looks like you're doing that very effectively. Yeah, so it's excellent, and I just want to wish you guys all the best with it.
Thanks so much. I'm very conscious Siobhan has to leave, and that's my fault. Actually, I ought to have come to you first, Siobhan. I know you have a very hard deadline. If you have the opportunity, could I ask you just if there was like any one big takeaway from your research which you would be conveying to us in our pilot that you think is probably, you know, the thing that you would most want us to be taking on board? Could I ask you to share that, and just acknowledging then?
And thanks again for engaging with such wonderful speakers today as well, to Sarah and Gillian, the project. I think by not talking about domestic violence, by not bringing it up in terms of our patient consultations, by not responding to what women are presenting with experiences, we are doing a disservice to them, and that really feeds into the shame and stigma that women have already living in violent, abusive relationships as well. So it's really up to us to break down that, and then also to really be thinking coherently about what we can do for women whose first language isn't English, who might have come here very recently, whose situation might be quite precarious as well too. And I know the question of working with GPs has been brought up, just to let people know as well that the updated domestic violence guidelines from the Isgp will be forthcoming. I believe they're going to be expected. I've been working with Dr. Lorna O'Doherty for the last number of months on them. So I think they'll be happening in about February 2022. They'll be launched, and obviously GPs are a very key part. They provide 9 of the free Maternity and Infant Care Act funded antenatal and postnatal care pieces. So they're definitely part of the jigsaw in terms of really responding effectively to domestic violence. So, but if we don't address the shame, stigma, embarrassment, and the hidden nature, the taboo nature of domestic violence and pregnancy, we will not be able to offer the support, care, safety that we need to for women experiencing violence during their pregnancies.
Yeah, thank you so much, Siobhan. I appreciate. I know you have to jump off, but those are really, really important parting words. Thanks for your research and your contribution. Gillian, I'm going to ask you just one question, which is slightly different. It's more just, I think it would be interesting for people to be aware from the kind of the specialist domestic violence perspective as to kind of what kind of tactics and behaviours are becoming perhaps more prevalent in terms of some of the different kind of tools that an abuser will use. And there was questions around the issue of digital surveillance, kind of online abuse for monitoring or coercive purposes, just giving that added layer of risk. So just from almost more from an awareness raising perspective and from your experience kind of working directly with women who've had that experience, what kind of things might be happening at the moment kind of that involve an even heightened level of vigilance around safety planning with women if they do disclose?
Mm-hmm. Well, I think, I suppose just to say, and I think if anyone comes away with anything, I think from my domestic homicide review work, what clearly is a red flag and is something that everyone needs to be like, okay, this is something we really need to consider safety here, is when someone talks about that they're separating or they're attempting to separate. So they might not even have left the abuser, but they're talking about leaving the abuser, then they want to leave the abuser and they're attempting. And they might have already left. So post-separation abuse is very high risk. We know that most homicides and murders of women is when they actually have separated, and even in the first year of actually separation. So I suppose just to say that is something that professionals need to be very vigilant about, is when someone is talking about that, because actually what I saw from the domestic homicide reviews is that you would have a lot of disclosures of that to health professionals, of women saying, oh, I'm thinking of separating, I want to separate, or I have separated. And there's, okay, there's that kind of thing. Oh, they're safe then, we don't need to do anything. But it's, and that was, just in those cases. I know that doesn't happen for every professional, but just to say that, it's not safe. They're not safe then. And we need to be actually even hyper vigilant of risk at that time and talk to the woman and make sure she has safety plans around her. I think, we obviously have, there's many tactics abusers use. I think a big one to consider is that, that restricted access to healthcare appointments, antenatal care. Why is the woman attending late all the time? Possibly why is, why is there always delay, why is there a delay in accessing that maternity care? As Dr. O'Doherty mentioned as well, like unplanned pregnancy is a really, really high risk. So it's kind of going, okay, pregnancies can be unplanned, of course, that happens all the time. But like, should we dig a little bit deeper here? Is this something the woman wanted? Is this, why is it unplanned? Let's have those kind of open conversations with her that actually might lead to something, what's going on with her life. I think it's very important to be aware that women are not, they don't, it's not always like I'm experiencing abuse, because as you mentioned, women don't always just say abuse. They don't use that word. They might say the word, but they might say, oh, my partner, oh, he's he can get annoyed, or he can get frustrated at times. He's a bit stressed. So instead of just kind of, and I know there's a lot for health professionals to deal with when they're in that one meeting with women, but just to kind of be aware of, okay, stressed, annoyed, frustrated. Oh, tell me more about, your partner and life at home, and tell me more about what's going on. Just kind of open and inquire and lead that open conversation. And that trust, if you create that environment of trust, women will disclose a lot.
Thanks, Gillian.
Yeah,
I'm good. We could go all day, but we are going to have to draw to a close because we are just coming out of time. I want to just a couple of practical things to let people know. We, as you know, we'll be sharing the recording afterwards, and also the materials that Gillian was talking about as part of the awareness campaign within the maternity healthcare setting. Those resources can be downloaded from the women'said.ie website. If you just search Maternity Project, there's all those links there. And if you would like a pack, you can contact Gillian directly. gillian.dennehy@womensaid.ie for like a hard copy pack, or as I say, for environmental reasons, if you wish to download, that's even better. I just want to acknowledge one thing before we close, and again, thanking the great panel, the huge interest from our participants, is that as always, when we actually talk about this project, there is just such an appetite from all cohorts in the health sector, and it's come up in the comments in terms of mental health practitioners, GPs, our community-based nursing teams, and there are these questions as will it be for everybody, will it include everybody? And you know, I just have to say this is a pilot, and so being a pilot, what we hope is we will be working in a very focused way with the resources that we've been lucky enough to bring together, and the evaluation then will be absolutely crucial, because what that will look at is the applicability of this model for a range of different settings. So our objective, with the support of and influence of our excellent external advisory panel, which has representation from people who are involved in the National Women's Health Strategy, you know, as I say, high-level social work and obstetrics and other areas, is to make the case for the resourcing of this, because this can't happen in an ad hoc way. It has to happen in a systematic way where everybody is moving together, working together to the same aim. So while we regret that we won't be able to train everybody, we hope that this pilot and this awareness work, which of course the materials are available to absolutely everybody, we hope ultimately this will create connections with all of the specialist services around the country in a way that people are resourced to do, are given the time to do, and are given state support to do, because ultimately something like this really needs to be mainstreamed and endorsed as part of national health strategies. So what we hope is that we'll make that small contribution to make the case, which then will lead to something that's more mainstream. So in the meantime, I encourage everyone to use your informal and formal networks to collaborate, you know, to share, to learn. I hope that the resources we have available on womensaid.ie can continue to be a resource. Likewise, our frontline national helpline for you as a practitioner. And I just want to thank you all for attending today, and we'll draw this webinar to a close. Thank you all so much. And thank you, Amanda and Tracy, as always.